Yep, don't worry. Groundhog Day will be over someday.
December 19th.
That's very selfish.
All right, we're gonna do just a little bit of review on EKGs. I know people think it's a scary topic. In emergency medicine, we do it a little bit, hopefully more simply, or at least I think it's a little bit more simple than like you would with cardiology and trying to identify everything. For us, like I said, we're looking for those differentials as a consequence. What's gonna, what can harm my patient right now? What do I need to rule out? So we'll start with a brief EKG review. But we'll do some check on learning first. All right. So let's say you got like a 20-some-year-old male. He presents with chest pain, shortness of breath. He's stable, vital signs are stable, and you get this chest X-ray. What's your treatment or initial treatment of this patient?
What's stable or unstable?
He's stable. Yeah, tube thoracostomy. So stable patient, no signs of tension physiology. You've got, a large pneumothorax here, relatively large. So we would do a tube thoracostomy on this patient. Now, what if this, let's say the patient, he was hypotensive, tachycardic, tachypnic. What would we do at that point?
NCD.
NCD followed by a chest tube. So that'd be tension physiology. So we want to do something more emergently in that patient. And then what if, not this chest X-ray, what if it's like a small, maybe 1 centimeter pneumothorax? You got like a primary spontaneous pneumothorax in like a young, healthy patient, and they're stable. What is our treatment for that?
Observation.
Yeah, oxygen. We can observe for 4 hours is like a common time frame, and then we get a repeat chest X-ray. Good. That pretty much sums up all your pneumothorax lecture there. All right. So this patient is hypertensive, sudden onset, tearing chest pain, radiates to the back, EKGs, non-specific T-wave changes, D-dimer's elevated. You see the following chest X-ray. What's your initial treatment for this?
Beta blocker.
Yeah, what beta blocker do we like to use? Esmolol. Yeah, esmolol. You can use labetalol, but esmolol's a more common one we use because it's faster on, fast off, and we can control the drip rate. Good. What if they have a contraindicator to a beta blocker? What would be our medication of choice or treatment? Nicardipine would be our treatment of choice from that one. Good. And nicardipine has rate control and it has antihypertensive properties. So normally alone it may not control it enough. We may have to add something to that for vasodilator, but it does work if they have allergy beta blockers. Good. That's all I have. All right. So here's our approach to EKGs. So we look at the rate, rhythm, intervals, what kind of morphology do we see, what's the axis, is there hypertrophy, ischemia, infarction? And really what we're looking for in the ER is any sort of arrhythmia, or we're looking for any sort of ischemia or infarction are the big ones. We're looking at everything else on an EKG, could be helpful if we're worried about some sort of like left ventricular hypertrophy, maybe they have heart failure. They're like subtle indicators, but nothing that you can really hang your hat on. For us, we're worried about anything that can kill that patient. So really the, infarction's the big one, and then any sort of arrhythmia like VTAC, AFib, any, like if you remember those syncope lectures, any, delta waves on there. For WPW, there's heart blocks, long QT, but we'll talk about it a little more throughout the lectures. But here's our rate. So in the ER, we look at it. Is it fast or slow? I like to use the big box method. I don't know, maybe I'm not that smart, but I don't like to do any real calculations. So this one's one big box, 300, and then you just count them. 2, 150, 3, 100, 4, 75, 5, 60, anything over, if it's greater than that, then the rate of cardiac. Anything over 100, we know it's fast. Does that make sense to everybody? All right. And then this is just a breakdown of some of our like seconds or time frames throughout that. Kind of a complicated slide. And unfortunately in medicine, we like to make things even more complicated. So sometimes we'll say it in milliseconds, sometimes we'll say it in seconds. And this just goes over, like one small box is 0.04 seconds. One big box, we're looking at 0.2 seconds or 200 milliseconds. I don't know what all the calculations are on the bottom. That was like, yeah, like beautiful mind stuff down there. But the easiest way is find your R to R. Hopefully you can find one that lines up to a big box or close to a big box, and then you just count it out, whether it's 300, 150, 100, 75, 60. All right, next thing we look at is a rhythm. So is it regular or irregular? And then we look at whether it's narrow or wide. So, what are our concerns if it's wide? Or what kind of arrhythmia are we looking at? Or that we are most concerned for in the emergency department? Like, I guess it's kind of it's torsades. Really just like a ventricular tachycardia, because that could be a life-threatening arrhythmia. So then we want to look at it, whether it's, so if it's regular, we have boxes we put them in. If it's irregular, we have boxes we put them in. And we won't go over that because we're focusing on really the approach to chest pain, acute coronary syndrome in this lecture. All right, so here's some of our intervals. I mean, the easy way to remember, like our PR interval should be like one big box. Your QRS, anything over 0.1 is considered abnormal or large. So with those, we can look at like, some sort of bundle branch block. Is it a ventricular origin for this? Are they taking any drugs? And you guys actually see that a lot on normals. So it'll be, since the QRS is supposed to be 0.1, under 0.1, it'll be like 0.11. So it's not, we really say it's wider when it's over 0.12, but textbook says 0.1, and you guys will be doing a lot of like physical exams, and like especially like a special forces physical or something like that when you're doing them, and it'll say 0.11, incomplete right bundle branch block, and then they'll want you to send them to cardiology, and it's all a real big waste of time because it's it's a normal variant that you see very commonly. So it's something to think about, and whether you really have to refer them and waste the cardiologist's time. Then the QTC interval. So anything over 500 we say is clinically significant, but there are different ranges like 450 to 460 depending on whether they're male or female. Really, those are considerations, especially you guys are going to be given a lot of different medications that can prolong the QT interval. So it's just something to think about if you have an EKG prior to and you're given certain medications that will also prolong that QT interval. All right, then we look at our morphologies. So we start with our P waves. Do I have a P wave for every QRS? If I do, great. If not, then I want to consider, what is causing that, whether it's some sort of tachycardia, or whether it's some sort of atrial arrhythmia, like AFib. But we can also look at that morphology of the P wave and say, is it like peaked or tall P waves? So that's right, atrial enlargement or P pulmonalis, how we always remember it, and then P mitral if the P wave is wide or extended. And then, like I'd already said about the QRS interval, it can indicate whether there's a right bundle branch block like you see on the top. So you got that RSR prime or your little bunny ears. And normally, which direction does like V1 normally go for your QRS? Down. Yeah, so that's like an easy indicator. Okay, it's positive. Let me look at how wide it is. And then you can kind of decide whether you think it's right bundle branch block. And then for left bundle branch block, it's just whether it's wide or narrow in those, and then that could be indicative of a left bundle branch block. And the tricky part of the left bundle branch block is sometimes it used to be a STEMI equivalent, it no longer is, but there are measurements we can take to help us kind of identify if we still think it's acute coronary syndrome, because it can be kind of tricky when you have that V1 widen for the left bundle branch block. So does anybody remember the name of the criteria we use? It's a funky name. Scarbosa. Somebody was starting to say, yeah, Scarbosa criteria. We won't get into it. All right. And then our T-wave morphology can look like anything, really. So they can be kind of difficult. You might have you might have a biphasic T-wave, and that whole block, or that whole top block up there after the normal is what we just call nonspecific ST and T-wave abnormalities, which we see very commonly. It isn't indicative of any specific pathology, but sometimes depending on the morphology on the bottom. So if we have those peak T waves and you see it across all of your leads or all of your T waves, then you could think maybe some sort of hyperkalemia or electrolyte abnormality. And then the important things we're going to focus on today are those ischemic ones. So, and then our ST elevations. And then here's our axis. This isn't an EKG course. I'm not going to ask you what the axis is. But it is important to remember that it swings towards hypertrophy, away from ischemia. So when we're looking at it, we look at the EKG, and we think maybe they're ischemic. This can help us this can help guide us towards that. And we're saying, okay, so it's we have that right axis deviation. There's ST depression in some of those leads, and it can kind of help guide you. Okay, that makes sense because it's on the right. This right ventricular infarction or something like that. Or sorry, that would be left in that one. All right. So we have our left ventricular hypertrophy. You should see some left axis deviation because it's going towards the side of that. The electricity is going towards the hypertrophy. And that's really anything over 35 millimeters when you add it up with those two leads, V1 and then V5 or V6. And then, that's a common abnormality. We'll see left ventricular hypertrophy. Sometimes it's normal variant, depending on, especially like young, healthy, more athletic patients, you'll see some it'll look like left ventricular hypertrophy on there. And then right ventricular hypertrophy, you should have that right axis deviation in your left leads. You can add them up again with, V1, R greater than S, V6, S greater than R. And then here's what we're concerned about mostly with our approach to chest pain. So we want to look for any sort of STEMI criteria, so over 1 millimeter in two contiguous leads, or 2 in V2 and V3. Then we want to look for any depression or reciprocal changes on there if we do see that. Then we can look at those T-wave abnormalities. So whether we have those deep T waves you see with Wellens, we always remember to digging a grave. Do you guys remember the Wellens criteria, like V2 and 3 most commonly? You'll have those deep T waves, and we'll cover some EKGs with it in the lecture right after this. And then we have Q waves. So question is, are they pathologic Q waves or not? So usually they're at least a box wide and over 25% of the height of the R wave. And that can be indicative of some sort of prior infarction. What do you see like those dagger T waves and, or dagger Q waves, sorry. You guys remember that? Like a young guy with syncope. Yeah, like hypertrophic cardiomyopathy. All right, here's our evolution of myocardial infarction. So you have a normal QRS and ST segment on the top and T wave, and then as it progresses, so when it starts to infarct, you'll get those peak T waves initially, followed by some degree of ST segment elevation, and then eventually, once it infarcts, it will have the Q wave and loss of your R wave, T wave inversion. Hopefully, we treat it before it gets to that point. And then here's a great pictorial representation to remember. So it is important that we identify on those EKGs, and I'm going to ask you, a bunch of questions on it, or have a bunch of EKGs and ask you where do you think the infarction is, or where's the STEMI? So, we have 2-3 AVF as our inferior leads. Then we want to look for reciprocal changes, usually in our lateral leads, and then we have, a lateral STEMI, anterior, septal, and we'll go over some EKGs here in a second to kind of demonstrate those to you. It is important to remember which coronary artery is affected by these. So Your inferior, we worry about the RCA. Those lateral leads could be the LAD, or it can be septal as well. All right, and then here's a picture for you. I don't really like it. I don't have a great way to explain it, but if this is your learning style, you can look at it. All right, this is important. So when we're looking at reciprocal changes, you guys remember the Pales mnemonic? So posterior, you look anterior, anterior, look inferior, yada, yada, yada. So it's important when we see that, when we see some sort of ST elevation, we want to look, is it in contiguous leads? And then do I have reciprocal changes? So is it an infarct pattern on this EKG? The tricky part is, 30% of STEMIs might not have reciprocal changes. And we'll show some EKGs here that demonstrate that. All right, what do we see on this one? You guys probably have the answer on your slide, right? Yeah, this is going to be your lateral. So what leads do you guys see the elevation in? Yeah. You got one AVL, V, 5 and 6 definitely, maybe V4 on there. And then where do we see those reciprocal changes? Yeah, the inferior leads, right? So a little bit in 2, definitely in 3, definitely in AVF, good. What about this one?
Inferior to inferior on the slide.
Yeah, that one looks inferior, right? And then where do we see reciprocal changes in this? Yeah, AVL is most obvious, yes. And you don't really see much in the other lateral leads. And so, yeah, if you guys remember back to your EKG days and cardiology, what kind of EKG do we want, or what are we worried about with this when we have this inferior MI? What specific kind of EKG do we want to get? We're like a right ventricular EKG for this one, yeah. And we'll go over some examples of when, what to look for a posterior lead, and hopefully we can make it easy to remember. All right, what do we got here? Kind of stem. I know it's small. What are we thinking? Inferior? Everybody agree? All right, and so we want to get our right-sided or V4R EKG to help us decide whether it's whether it has any right ventricular involvement. What else do you guys see on that EKG on the left? If you're just starting out, what's the rate? That's probably just under 100, right? And then is it regular? No. Yeah, it's irregular. And then we look at, does this one have a P wave before every QRS? And it looks like there's a P wave buried down there on the right without a QRS complex there. So then we want to look at where the rest of our P waves are. Does it look like some sort of heart block? Does it get longer, drop, with our Winky block? Is it, type 3, complete heart block? It doesn't look like it is. All right, yeah, there's a right ventricular infarct. What do we see on here? Let's look at this one. So this is our right-sided EKG. So we did V 4, 5, 6, 7, 8, 9. This is a posterior MI. So one of the ways, this one's a little bit more subtle, but one of the ways we can look at this, so if you look at the EKG on the left, a lot of times you'll see if it's a posterior MI the way I was taught, and it's a little bit more obvious on the right, but you see the ST depression on like your V1 and 2 leads, and I was always taught when you see that and you don't see any sort of elevation in those other leads, you think about flipping your EKG over is kind of how you look at it for that posterior MI, and then that basically can help kind of identify, oh, maybe that there's elevation if I flip it over, so maybe I should get a posterior EKG for these patients. If that made sense. Makes sense in my head. What do we got on this one? You see anterior ST elevation, septal. This is like septal MI. So you got V1 and V2, certainly have elevation, questionable elevation in V3. Do you see any reciprocal changes? I don't really see any on there either. All right, good, good. And here's another example. This one's a little bit more subtle. What do we see on here? Yeah, this one, so we don't have any reciprocal changes. This is an anterior MI. The tricky part when it's very subtle like this, so maybe there's, it's over 1 millimeter, maybe 2 millimeter in some of the leads. So an easy way, if you have your EKG, you just kind of fold it to give you a straight line across, so because you want to figure out where your baseline is. So you want to go, because if you look like, it's hard to tell whether the PR is depressed versus whether there's elevation on there. So that's an easy way, and you can get kind of a baseline across the tracing, and then it makes it a little more obvious for these subtle ones. All right, we're gonna move into chest pain. That's our favorite in the ER. All right. So there's our little Tintinolly references. And then here's our objectives. So in emergency medicine, we want to, approach every patient with chest pain the same because we don't want to get burned. But here, we have to understand, what risk factors they have, what their age is, how they're describing their chest pain. And then we want to look at what causes, what can be our deadly differential diagnosis for these. So, acute coronary syndrome 1, PE, dissection, you got your esophageal perforations or ruptures, tension pneumo, pericardial tamponade. And these are, diagnoses that we need to treat, or we need to rule out when we're evaluating all of our chest pain patients. And some of that we can use with ancillary testing. Some of it, we can base it on history. But, for all intents and purposes, anybody with chest pain, we normally get an EKG on them. So, it's not wrong to get an EKG. Even if they're young, they come with chest pain, we want to get an EKG on them. And then we decide where we want to go from there, whether I think it's acute coronary syndrome, whether I need to get my troponin, D-dimer, whether we need more imaging on top of that. And we'll get into a little bit more on the causes. I don't know why the take-home points are at the front. I probably should change it, but this is just a brief overview, which is what we're going to talk about today and go through all of these. But we'll start with some practice EKGs and cases here. But really, we want to decide whether it's an acute coronary syndrome or acute myocardial infarction. There's a lot of different terminology. They wanted to try to change it to occlusive myocardial infarction. But what we're trying to do is figure out if it's a STEMI versus an NSTEMI versus unstable angina. So anybody that presents chest pain, we have to get a EKG within 10 minutes. And then we set up our safety net. So we get our IV access, put them on the monitor, oxygen if we need it. And then we evaluate that EKG and decide whether there's ST elevation on there, whether there's any depression, ischemia, and if not, then we have to look at some of our other metrics like troponin. So, troponin will be elevated with an NSTEMI. And then we need to decide whether this is, acute coronary syndrome versus a different pathology. And we use the heart score for our low risk chest pain. So we call it risk stratification. And we'll get into the heart score here, but it is something important to remember. You can look it up on an app, like MD Calc has a calculator on there. So if we diagnose acute coronary syndrome or NSTEMI or STEMI, then we need to look at what the next treatments are. So for STEMI, they need to get a PCI within 90 minutes if we're at a PCI capable facility. And that just means percutaneous intervention. So they stick a little catheter into the coronary arteries and they shoot some dye in there to try to figure out where it's infarcted at. If we don't have a PCI facility, like one of the places I work is a freestanding ER, so we don't have PCI capabilities, so we have to get them somewhere in the next 120 minutes or 2 hours, and we need to give them some sort of fibrinolytics within 30 minutes of them arriving, and then get them out the door into that facility in 2 hours. If we can't do that, we still treat them with fibrinolytics. And then we try to get them somewhere appropriately. So if you're in a rural place and you're multiple hours away, it might be a little more difficult. Or you might have to call in air-evac. And then everyone gets aspirin that we're concerned for acute coronary syndrome. They show up with chest pain, so we give them 324 milligrams of aspirin. We have them chew it. And then we give them anticoagulation if we think it's a STEMI. So and that's usually with heparin. You can use Lovenox, but we normally use heparin just because it's quick on, quick off, and it's a drip. So you can turn it off if you have any bleeding issues or concerns. And then if everybody should get nitrates or some sort of nitrate if they're not hypotensive and it's not an inferior MI. And then, like I said, definitive treatment, PCI for everybody. So let's get into some intro and practice here. Pretty common, and it's also commonly misdiagnosis too for acute myocardial infarctions. It's like, you'll see a ton of chest pain, like 10% will probably have some sort of acute coronary syndrome, according to the statistics. All right, let's do a warm-up case. So 78-year-old male, brought to the ED by EMS, complains chest pain, describes it as chest heaviness, shortness of breath for the last hour while working on the computer. EMS gave him 324 milligrams of aspirin en route. Vital signs are 94/66, heart rate 102, respir 16, pulse ox 98, physical exam, well nourished, well developed male, moderate stress. What do we see on that EKG? Yeah, inferior STEMI. Yep, good. So what do we want to do? What other kind of EKG do we want to give for this patient? Yep, right side EKG. So this is like your classic code STEMI. Some places will call it a heart alert. Just depends on your facility and whether you have PCI capabilities or not. So what do we do for them? So yeah, we call the code STEMI, activate the cath lab. If we don't have a cath lab, then we can give them fibrinolytics and transfer to a cath lab. We give him, he's already gotten aspirin. We want to look at getting some sort of heparin on board to anticoagulate him and nitrates. This patient, I wouldn't give nitrates to. He's got soft blood pressure and an inferior STEMI. All right. The next one, you got an 80-year-old man, presents AD with chest pain. You obtain the following EKG. What is your interpretation? What's this one? Anterior? Lateral? Yeah, inferior again, right? Good. And do we see reciprocal changes here?
Yes.
Yeah, you do, right? We see reciprocal changes, most prominently in 1 and AVL. All right, so here's the interpretation. This is inferior MI from right coronary artery occlusion. And then it kind of explains what we talked about on that EKG already. He had 100% occlusion, so he found during his cardiac catheterization. Let's do another one. So 65-year-old man presents with ED with chest pain. Here's your EKG. What is the interpretation here? Yeah, it looks like it. Yeah, aneroseptal. You have reciprocal changes on there. Good. This is proximal lat occlusion. All right, let's move into acute coronary syndrome. So we have, three different terminologies we use here, three different pathologies we're trying to identify. So acute myocardial infarction is STEMI or NSTEMI, and then we have acute ischemia, which is unstable angina, which is, on the top we have some sort of occlusion, whereas the unstable angina, they'll have some sort of stable lesion on there, and maybe they've increased their exercise, but you don't see any pathologic findings. They don't have any cardiac biomarker elevation, but they do have a risk for eventual myocardial infarction. And we'll talk about how we risk stratify those patients with our heart score and other treatments. So there's like our exercise-induced myocardial ischemia, which is our stable angina. And these patients usually have a fixed atherosclerotic lesion that we find. They've usually been evaluated by cardiology. They might have had a heart cath already, and they didn't require any stents on there. And usually these patients will have, some sort of nitrate that they can take if they're having their chest pain with, some certain amount of exercise. And then if we compare that to our unstable angina, so we've got some sort of issue, like you can also have a coronary arterial spasm. And you guys remember what we think of that with not most commonly. Yeah, good, like Brinsmetal, it could be from like a cocaine induced. But this one has some sort of atherosclerotic plaque, and maybe there's some sort of erosion and rupture, but it's not causing complete occlusion or any symptoms on our EKG. So, and there's our pathophysiology. So you got that, some sort of atherosclerotic plaque. It ruptures, it occludes one of the coronary arteries or blood flow, and it creates that chest pain, it creates ischemia to the heart. And then you get some sort of, mismatch, and it start, the ischemia can then lead to infarction, and that's where we want to intervene before it reaches that point. And then here's just showing like our graphic of blood flows completely cut off, so necrosis, versus you just have decreased blood flow to that area from wherever that plaque is. So what do we do for our initial assessment? So like everything else, we do our ABCs, we get our safety net involved. When they present, if somebody presents with chest pain, they might be diaphoretic, we want to initially evaluate their vital signs because they're vital, and then we resuscitate appropriately depending on that. So if they have hypotension, we're going to give them some fluids, we're going to get them on the monitor, everybody gets aspirin for any sort of acute coronary syndrome, and then we give them nitroglycerin if they can tolerate it, and it's not inferior MI, and then that's our standard kind of chest pain labs we get on there. So everybody gets the CBC, CMP, we get our coags, and a troponin. So the other ones, if we have a concern for heart failure, we add the BNP on there, or if the diagnosis is in question, or if we have any concerns or suspicion for pulmonary embolism, we'll get a D-dimer. And anything 90 or below, we usually give them oxygen as well. You guys remember like the old Mona term? Yeah, we don't. Yeah. All right. So there's our goal. Want to get that EKG within 10 minutes, and it needs to be interpreted by a provider, and that's usually pretty quick. If they show up at triage in the emergency department, they have chest pain, they get the EKG right then, and then somebody walks it back to a provider, and we take a look at it and decide whether, we think it's STEMI versus NSTEMI versus normal. All right, so what's our classic history for, acute coronary syndrome? So they have some sort of chest pain. They usually describe it as like crushing, an elephant sitting on my chest. They might describe it as pressure, tightness. You can hear a lot of different descriptions of it. A lot of times it'll have some exertional component. They were, walking, going upstairs, and then it could be relieved by rest. Usually if it's anginal pain, it's short lasting, so like 2 to 10 minutes is stable angina. Unstable, we're usually greater than that, 30-minute mark. And then anything longer than 30 minutes is more suspicious for acute myocardial infarction. Other classic histories, they have jaw pain with it, they have pain radiating to the arm, the neck, and I already said diaphoresis, shortness of breath, can have nausea, vomiting. These are all the classic descriptions of acute coronary syndrome or STEMI. And then our non-classic. So this could be short, pain lasted only seconds. It was like a sharp stabbing pain. They can have, waxing and waning. It's intermittent, so it only happens at certain times of the day, or it only happens, at night. And then it can be positional chest pain, nausea, upper back pain, weakness. And these are more frequent in women, diabetics, the elderly. And this is why we get an EKG in all of the patients that present with chest pain, no matter how they describe it, because everybody presents differently. Important history questions are some of these anginal equivalents. So one of them is any history, have they ever had any prior myocardial infarction? And if they say yes, we want to know, does this feel like the last time this happened? Did you have a chest pain like this? And a lot of patients that have had it, they will say, oh, yes, this is exactly like it, or they'll say this is worse, or they'll say, no, this isn't like it at all. I don't think I'm having a heart attack. But we want to look at whether they have any shortness of breath, any chest pain with exertion, nausea, lightheadedness, mental status changes. One of the tricky ones is that epigastric pain, so that can sometimes trick us into thinking, that's probably some sort of reflux, GERD. Let's give them some antacids and see if we can fix this. The issue is, even if it's relieved, it doesn't rule out a myocardial infarction. So that's why all these patients are going to be treated the same when they show up with chest pain. So at a minimum, they'll get an EKG. Sometimes you'll see a lot of young 19-year-old healthy soldiers with chest pain, still get an EKG in them. And then we kind of decide whether we need to get our troponins or any other lab studies on top of that. But other ones, like I said earlier, or in some of the other lectures with family history, really we care about those first degree relatives and if they died at an early age of a heart attack. So if somebody's like, oh yeah, my dad died at 40 of a heart attack, so did my brother, that's really concerning, and you should probably work that patient up a little bit more. All right. And there's there's different mnemonics for OPQRST, old CARTS is another one. But really we're just trying to qualify that chest pain. So, when did it start? Where's it at? Can you point to where it's at? Is it left-sided chest pain? Is it right-sided chest pain? And then how do you describe it? Is it, sharp? Is it dull? Is it stabbing? Is it pressure? And then we look at what caused it to start? Were you doing any exertional activities? And then does it radiate anywhere? And the big ones are does it radiate? Do you have any jaw pain with it? Do you have any arm pain with it? Any neck pain? But ones that are strongly suggestive, any exertional component, any diaphoresis with the radiation to arms, neck or jaw, vomiting, and then similar to their past or an anginal equivalent. And then here's some of our coronary artery disease risk factors. So anybody over 40, male, postmenopausal female, hypertension, tobacco use, any hypercholesterolemia, diabetes, family history, sedentary lifestyle. It's important to know these because we're going to calculate a hard score in our patients to assess their risk or risk stratify them. So we want to know any of these factors in here, and that'll help us calculate their hard score later for risk stratification. Or initially when they present, this will increase your suspicion. Yeah, I think this might be an acute coronary syndrome. Physical exam. So most of the physical exam, is relatively normal in most of the patients. Unless it's that inferior MI or depending on how large of an occlusion it is, a lot of times you'll have stable vital signs. So really, you don't find a lot on your physical exam in these patients, but we want to look for other causes. So I see, is there any sort of edema in the extremities? Do I think this is heart failure? Pulse discrepancies for like a dissection? And then we do want to assess a brief neurological exam on these patients. So, heart rate could be normal, fast, slow. If it's slow and they're having acute coronary syndrome, that's more concerning in that patient. And we see that more with inferior wall MIs. All right. So, we do worry about like any new systolic murmur. So if you hear a murmur, they don't have a history of one, then we have to worry about like a papillary muscle dysfunction, some sort of mitral valve pathology or ventricular septal defect. Usually by the time they're, presenting with acute myocardial infarction, hopefully they know if they have a VSD or not, because they probably had it their whole life. All right, so the first thing we need to do is get that EKG within the 10 minutes. If we have acute coronary syndrome differential, we get a chest x-ray, our cardiac biomarkers, our coag, CBC, CMP, and then when we interpret it, if we have that 1 millimeter and at least 2 contiguous leads, then we need to activate the cath lab and call a STEMI. If we see ST depression, we'll talk about how we manage that as well, and what those risk factors are for whether they're going to need a cath or not. And then even a normal EKG doesn't rule this out. So a lot of it's going to be based on how long they've had the chest pain, and then what their initial EKG is, troponin, and then we decide whether we're doing serial EKGs. Could this be an evolving acute myocardial infarction or STEMI? So there's a lot of different pathways we use here, but our best diagnostic test can be our EKG. Pre-hospital EKGs, so depending on where you're at in your EMS system, they may get an EKG initially when they show up at the patient's house, and then they can decide whether they're going to a cath lab and activating it right then versus going to a different facility. So you may have a pre-hospital EKG, and some places can transmit it over to you as well, which is nice. All right, so like we've said, STEMI, they have EKG changes. And NSTEMI is they have some sort of elevation in their cardiac biomarker. So their troponin's elevated, but I don't see any ST elevation on that EKG. And then unstable angina is EKG and biomarkers are normal or non-diagnostic. And then we have to decide what we're going to do for risk stratification for those patients. And usually we calculate a hard score, and we look at whether we need to keep them here and do maybe a stress test on that patient, or whether they need to activate the cath lab for it. And so we'll look at that with risk factors. But that'll be later in the lecture for our hard score. But here's our chart, which we already covered, different way to look at it. And it's just looking at which leads are going to show ST segment elevation on the EKG. So, and which one it's associated with, or whether it's inferior versus lateral. So we won't beat the dead horse. So, like I said, we call them different names. So OMI, like obstructive myocardial infarction, occlusive myocardial infarction. And they change the name every few years. Like when I went to IPAP, we didn't call it NSTEMI, we called it non-ST elevation acute coronary syndrome. I think people just like to feel important, and they just change names every few years in medicine. You'll notice that. Like I said earlier, inferior wall MIs, we need to get that right-sided EKG so we get that V4R. And then anybody with a right vent infarction, they're preload dependent, so we don't want to give the nitroglycerin. We don't give beta blockers for that, which we don't give the beta blockers anymore initially for these patients. And then an important other mnemonic to remember is when you're looking at T-wave inversion. So have you guys ever heard like a flip T-wave and 3 is free? So T-wave inversion, 3 is free. So reciprocal changes, on the opposite from where we have that ischemia or that infarction, we'll see that ST depression or reciprocal changes. And that just means it could be a larger area of injury risk, increase their severity. For like those inferior ones or larger portions, we worry about pump failure and cardiovascular complications. But like some of those EKGs like you saw when you have all of the leads elevated and they're significantly elevated, more extensive injury risk. And then here's our posterior MI again. So like I said, when you're looking at like B1 and 2, if you kind of flip it over, it kind of looks like there's ST elevation in there, and that can kind of help guide you to that posterior MI. And then you get those posterior leads on there. So if you see, you have that deep ST depression in V2 is most commonly. So at this point, we want to get that like posterior V789 on there. All right, there's our right-sided lead placement. So really we just flip-flop the leads when we're getting a right-sided. We can also get that V4R. And then we can also perform the posterior EKG. So really under the scapula, you put 789 on there, which I know you guys practiced during your EKG class. Even though the EKG machines didn't work, you at least put the leads on and attached them. Our machines are a little old. So, we do frequently misdiagnose patients with the EKG. So, the false positive rate can be 11 to 14%, but there's also false negatives, which is why we tend to treat most of the chest pains the same. We get the cardiac biomarkers on them. And then you have machines now that have interpretations on there that are relatively accurate. So they even have AI machines out there now that, comparing to like emergency physicians are relatively good. They correlate well. But the bottom line, don't rely just on the interpretation yourself. You want to evaluate that EKG because it does miss some things on there. Especially if you're worried about some of those arrhythmias, it may misinterpret it. All right. So we already talked about this. Our 12-lead EKG is great. Think about the right-sided EKG, V4R, or your posterior EKG, depending on what the presentation is or what the initial EKG shows you. And then we're going to move into Wellens syndrome. So this isn't considered a STEMI, but it has a very high risk for a STEMI in the next, 8 to 9 days on here. Really, we quantify in like the next 30 days, they have an extremely high risk. And so we look for these deep T waves or abnormal T waves in V2 and V3, and this is associated with critical stenosis of the lab. So when we see this in a patient, we want to increase our spidey sense. So, okay, they're not having a STEMI right now, but they have a very high chance that they're going to have one in the near future. So, 3/4 of the patients will develop it, and we'll take a look and show you what it looks like here. So, here's our classic Wellens. So you have those deep T waves in V2 and V3, and this one has in V4 as well. And that's commonly what you'll see on an EKG for what we call Wellens syndrome. And this just increases their risk for myocardial infarction. So when you see this is somebody we don't want to send home. They're not having a STEMI right now, and their biomarkers are likely going to be normal. But we still need to think about this when we're evaluating it, and we should probably keep them in the hospital, consult our cardiologist. They'll decide whether they're going to do a cath or not, which they usually will do a cath. There are other criteria for this, but we won't get into it. Sometimes they'll have a biphasic T wave on there, but we won't get into different types of the Wellens. This is going to be the classic one that you guys need to identify. So here's some of the history you see with it. So episodic chest pain, intermittent chest pain, Sometimes during the pain, EKG may be normal, but typically we see those deep symmetric T waves. We always call it like digging a grave. And really everything else is going to be normal on that exam, like their ST segments and biomarkers. All right, let's talk about our cardiac biomarker. So we look at our troponin for this. And this one's going to be this elevates early, usually within the first 6 hours, and it peaks and then starts to decrease at 24 hours. And this is our biomarker of choice. Some of the other ones we used were like CKMB, which can be indicative of the muscle tissue, heart muscle leaking certain proteins from it. So we found that it wasn't as accurate as an elevate in the appropriate time frame. Some places still have them, like one place I work still has a CKMB on it. And when we order that panel, I don't know why, but it's probably because it's more of we had a point of care lab test machine that we use. But we also want to get our CBC, CMP, coags, and then we decide whether we need any of the other ones on there, like the BNP, D-dimer. This is some of it's going to be like style. Some places will always get a mag and FOS, some places won't. Everybody gets chest X-ray, and really we're trying to rule out other causes when we're getting that chest X-ray. So it's not going to help us or be indicative of any acute coronary syndrome, but it can identify whether maybe this pain is from a pneumonia. Maybe they're having heart failure. All right. The tricky part with troponin is a single troponin can't rule out a STEMI if they present, within the first 6 hours. So normally we have to wait at least 6 hours before we can draw troponin. We get the EKG, it's normal. We get a troponin. If it's under 6 hours, we can't rule out acute coronary syndrome or NSTEMI. So we want to get serial measurements. So we call it delta troponin is what we commonly call it. And there are different time frames for it, depending on if they're high sensitivity versus, your standard troponin. So the new high sensitivities are 2 hours after presentation. It can detect it. A lot of facilities now will have an even newer test that can detect even smaller amounts of troponin. So just at your facility, figure out which one you have. The standard for high sensitivity is 2 hours. Now it could be 1, but we're not teaching that yet. But it is at like the facility, like Darnell has the like super high sensitivity, so 1 hour you can rule it out. And then there's our elevation, our typical elevation of our troponin. So usually, we should see changes or they should release it at about 6 hours, and then it peaks at 24 hours, and it starts to decrease after that. So, if we have a STEMI, great, clear cut, we have ST elevation, call the cath lab, activate the cath team. It gets tricky when we don't have any changes on there. Then we look at those biomarkers and we have to decide whether it's an NSTEMI. The treatments are kind of the same, and we'll talk about that, but NSTEMI means they're going to get a cath, but they're not going to get it in the next 2 hours. So usually in the next 24 hours, they'll still get a cardiac cath. We just don't have to rush as quickly or activate the cath lab. And the troponin is sensitive, specific. It's great as long as they present within that correct time frame. We can measure it. That delta troponin, we want to get 2 hours after the initial to help us rule out an NSTEMI. And like I just said, some places 1 hour, like Darnell switched to 1 hour troponins when I was there. Imaging, so chest X-ray, we're looking for other causes. So do they have any pneumothorax? All those deadly causes that we talked about, they have wide mediastinum, glycemia, cardiomegaly, fusions. And then you can do a portable bedside. A lot of times the patient's ambulatory, they'll take them down to the radiology department and they'll get a chest X-ray. We can do our bedside echo or ultrasound, looking for any effusion or wall abnormalities. All right, let's get into risk stratification. So here's our fun part. So once we've decided whether they're having a STEMI or an NSTEMI, and we've ruled that out, then we have to decide what's their risk. And the studies were over 6 weeks, but we need to decide what's the risk of having like an acute, or we call it major acute coronary event. And when they did the studies, that was based on like mortality or ACS in the next 6 weeks. So we used a heart score. It's been a validated tool that we've been using for a while, and we look at the history. So, and this is the most subjective part of the heart score. So you get 2 points for history and whether it's slightly suspicious, moderately, highly suspicious. And when we say highly suspicious, we mean those classic chest pain symptoms. They got diaphoresis, they've got that exertional chest pain, they got radiation to the jaw, arm, neck. Those are highly suspicious, and then anything else kind of falls into that moderately versus slightly suspicious, so it's very subjective on these. The studies, they've found that in the ER, we tend to give them a higher heart score versus like a cardiologist because our concern is they may have some sort of, acute coronary syndrome in the next 6 weeks. So, we probably overcall it, or at least the studies show we do. Then we look at their EKG. Do I have any EKG changes? And those are usually like non-specific changes or abnormalities, like your ST to new, like ST wave abnormalities, T wave inversions. And we add some points for that. Then we look at age, risk factors, and whether their troponins elevated. And here's our chart here. For when you're on your rotations, you can look, you can pull up MD Calc, which we use a lot of other tools like your Well scores on there, your Alvarado score. So, you can pull it up and look at it. In Genesis, they actually have a heart score that, it pops the box up and makes it really easy, and it tells you which one is which, and you can click 0, 1, 2. So we want to make sure we're evaluating this on any of these chest pain patients that we're sending home. So we get, computers, hang on. All right, so we look at age. So, under 45, they get 0. 65 and over, they get 2 points. Then we look at risk factors. And that's like whether they have, any sort of diabetes, history of hypertension, coronary artery disease, obesity. There are quite a few different risk factors that can be associated with this. So, if they have no risk factors, 0, 1 to 2, 1 point, 3 or more, then we give them 2 points. And this gets a little subjective as well. I mean, not really, but a lot of times we may not give a point for obesity. So that's just something you want to think about when you're looking at the patient and adding up all of their risk factors. And this is probably something we score higher on, especially in the emergency department. And then we look at their troponin level. So if they had a normal and 0 points, and then we look at 1 to 3 times normal limit or 3 times. Either way, if they have chest pain and an elevated troponin, we're going to admit them, and they're going to probably get a cath in the next 24 hours. All right, so some of our important adjuncts we need to do when they show up with STEMI or NSTEMI is making sure they get that aspirin immediately, so antiplatelet agent. Then we want to stop the coagulation, so we're going to give them anticoagulant. And normally that's heparin. Some facility, you could give Lovenox, and it actually is probably shown to, it's probably better. But we like to have something that we can quickly turn on and off, and then we give nitroglycerin. And we'll talk about why we give these in the next few slides. All right, so we got 90 minutes to restore blood flow. So once they present, we want to stop that platelet aggregation. We want to anticoagulate them, and then we want to limit the infarct size with our nitroglycerin. And then they need to get a PCI so they can actually stent that area of the heart and improve the blood flow. There it is again, 90 minutes PCI, 120 to a PCI facility. If not, give them fibrinolysis within 30 minutes. And And this just kind of explains our percutaneous coronary intervention. So that's we stick, they stick a long catheter usually in the radial artery, and they go all the way to the heart. And then they place, they shoot some dye in there, they place a stent. If there's multivessel disease, they normally get a coronary artery bypass graft. And that's a large surgery. So here's what it looks like when in the cath lab. So, it doesn't look super fancy. They'll have like their fluoroscopy. It kind of looks like a fluoroscopy machine. And then it can help identify which vessel. So they place that catheter in, they shoot some dye in there. As you can see on the bottom right image, you see that occlusion on there. So they can identify which coronary artery it is, how much occlusion, and then they can put a stent in there and open it back up. You guys will probably, watch some of these while you're in phase 2. I was always amazed because there's like 20 people in there, and I'm like, there's one dude doing it, and I'm like, why are there so many people in here for one? I don't know, maybe it takes that many, I never asked. All right, so multivessel disease, this is when they're gonna get that CABG. So this is gonna require them to open up the chest. You'll see a lot of chest x-rays from prior CABGs. They'll have those wires like you see up here. So you see those wires across it, that's from a prior CABG. Likely, I mean, there are other reasons to do a sternotomy, but that's one of them there. And then if it's, like significant left main block, they may do a CABG. And then any other dysfunctions they find there, like a VSD, ventricular aneurysm, that patient may be managed better with a CABG. And then here's what we do like at an outlying hospital. Oh, is there now? I'm not bad. All right, take a 10-minute break. Back at 10:55. Okay, so here's our treatment algorithm for like that outlying hospital or any hospital that doesn't have a cath lab in it. We want to stop the platelets with the aspirin, stop their coagulation, limit infarct size with the nitroglycerin, and then we want to give them a fibrinolytic within 30 minutes. Some used to call them clot busters, and that will help. That can help break up some of that clot, and then we want to evacuate them to another facility so they can get a PCI within 120 minutes. All right, so we're going to talk about fibrinolytics. So they have shown mortality benefits. They've shown that they can act on the thrombus and help either shrink it or help prevent any further clotting in that area. So the issue with fibrinolytics is they have risks. So they have significant risks with them. So the largest risk is going to be risk of bleeding. But it does restore blood flow if we give it in the first 30 minutes. And you can give it up to 6 hours depending on when the patient presented. It's door to balloon time, so we calculate our times based on when the patient presented. But the ones we use, like Alteplase and Tenecteplase, are the two that we use in the U.S. And Tenecteplase is becoming more common. We used to only use Alteplase, but now we have other options on there that show, pretty much same benefits. Tenecteplase may be a little bit more beneficial, but the data is still not conclusive on that. All right, so here's important considerations we need to think about when we're given the fibrinolytics. So we want to do this checklist in all of our patients that get it. So like absolute contraindications, if they get a PCI, that's the treatment, that's the gold standard, that's what they need. And then other contraindications, if they had a previous hemorrhagic stroke within a year, any sort of known intracranial neoplasm, any sort of intracranial or spinal surgery or head trauma in the past 8 weeks, active internal bleeding, or you suspect an aortic dissection. Those are absolute contraindications. And then relatives or their blood pressure, so that's something we can control in those patients. Any like significant trauma in the past 4 weeks, cerebrovascular accident, any recent surgeries in the past month, and then any sort of like diabetic retinopathy or hemorrhagic ophthalmic condition. Those are relative contraindications. So like everything in medicine, we need to weigh the risks versus the benefits and whether we're going to get anything out of this treatment. So they're not absolute contraindications, but we do need to consider them, and then we need to look at the risk versus the reward. As you can see, most of these are related to some sort of intracranial process, and that's where we commonly see the side effects from this. So there is a risk that that patient is going to have a brain bleed, so we do want to explain it to the patient. Hey, this has a risk of an intracranial hemorrhage. However, the benefits of us giving you this are going to be that we can open up that vessel, and you'll have a better quality of life afterwards. But we do want to explain it to them when we're administering this medication, so they know what the risks are, so they're not caught off guard if you have an intracranial hemorrhage. And it happens. If you still need to get that PCI. It says rescue PCI is recommended if they fail. We're giving the fibrinolytics and getting them to a PCI facility. Most of the places, or all the places I've ever worked, we were able to get somebody there within the time frame. We just, like here, they call it MedCom, and we just have to call them, and they decide whether it needs air evac versus ground evac. What sort of time frames do we have to get them there? All right, NSTEMI. This is, no ST elevation on your EKG, but you have elevated troponin or cardiac biomarkers. And for these patients, we still want to do our standard treatment, so everybody gets that aspirin, that anticoagulation with either heparin or Lovenox. We want to give the nitroglycerin if it's not contraindicated. And then we admit them to the hospital, and they don't emergently take them for PCI, but they'll get one during their hospital stay within the next 48 hours. All right, let's talk about some medications here. We'll talk about some of the different effects that we have for these and why we give them. So aspirin is an antiplatelet agent. We give every patient with chest pain that we suspect could be an acute coronary syndrome 325 milligrams of aspirin. It's really 324 because we give them 481 milligram tablets and they chew them. So every patient gets those. Just like it says, aspirin alone can help reduce the mortality by 2%. So it's relatively low risk as long as they don't have an allergy to it or history of PUD or GI bleeding. We're going to give them the aspirin. I think the number needed to treat is 41 patients to show a benefit, which isn't important to completely understand that now, but as you practice more and more, you'll realize certain medications really don't have much of an effect, and you'll look at the data a little bit more. If they have an aspirin allergy, we give them Plavix or what we call clopidogrel if they have an aspirin allergy. We want to stop those platelets from aggregating. There's other antiplatelet agents that we give on top of this. However, we do in consultation with the cardiologist. So there are newer medication like tiafaban or epsiximab. And that's usually given right at the time of the PCI by the cardiologist. So sometimes if you call the cardiologist, they'll tell you to give it right in the ER. It'll just be up to the facility and how quick they're getting the PCI. Then our anticoagulant, so unfractionated heparin is probably going to be our most used one. And it has been shown to reduce, myocardial infarction and death during the acute phase. So we give that aspirin, we give the heparin, and then it decreases our risk of death or acute myocardial infarction compared with aspirin alone. Combo therapy is indicated for ACS. Unfractionated heparin is quick on, quick off, so it's very rapid bioavailability. And there's our standard dosing for it. So we have, it says 50 to 70 units per kilogram. Normally we give 4,000 units of this. And then for like NSTEMI, they get 5,000 because the patient's probably going to be waiting a little bit longer before they get the PCI. So we want to make sure that they're appropriately anticoagulated prior to that to lower their risk. And then what we don't have on here, because we're getting them out of the ER, we also, if they're extended stay, we start a drip rate for these two, but you don't need to know that. And low molecular weight heparin has a better bioavailability, but it's a long half-life, so it's usually every 12 hours. So that's why we don't love to give it, just because if we have any sort of side effects with it, we can't turn it off. We know that we've given it, it's going to be in their system. So most places, you'll have a standard there, so just figure out what it is, whether you're using unfractionated heparin versus Lovenox or low molecular weight heparin. Either way, they need some sort of heparin on board for an anticoagulant. And then nitrates, we want to vasodilate them to help open up that coronary vasculature. We do have great data on it. It does help, it does limit the infarct size. And then there's your standard dosing on there, and that's usually for a sublingual tablet. We have paste we can give the patient. We have nitroglycerin drips, depending on what we're trying to control in this patient. We just have to remember if they're hypotensive, this is going to drop their blood pressure even more. If they have right ventricular involvement with that inferior MI, we don't want to give it. And if they have any phosphodiesterase inhibitor use, so that's like your Viagra and all those other ones, newer ones now that are a little bit longer acting, those are contraindications given nitrates. All right, so it's pretty significant mortality lowering rate with giving nitroglycerin, so it is an important therapeutic we can give them to help limit that infarction. And we just have to make sure we're looking at those contraindications for it first. And then, like I said, most serious side effect is hypotension, so if their blood pressure is already soft, we're not going to give it. If we have that inferior MI, we want to avoid it. And then anybody taking those, the phosphodiesterase inhibitors. There it is again. No phosphodiesterase inhibitors. All right. So here's the things we used to do, and they do show benefit. However, we used to give it to every patient when they presented. Now we hold off and wait for them to get their PCI first, and then we let the cardiologist start some of these other medications like beta blockers. But it's going to, decrease your myocardial oxygen demand, heart rate, blood pressure. So, and that's something we usually don't like to do during the acute phase or initially in the ER, but it is beneficial in the first 24 hours. So that'll be started by your cardiologist. ACE inhibitors, so, not something we give immediately in the emergency department anymore. It is recommended for patients in the first 24 hours. So once again, it's done by our cardiologist. Don't give them an ACE inhibitor in the emergency department. And then calcium channel blockers show no mortality benefits, so we don't give those. All right, let's discuss some complications here. So dysrhythmias are very common after a myocardial infarction. So we're usually having these patients on the cardiac telemetry monitor throughout their entire stay. And what we worry about is, there can be, like our biggest concern is usually like a VTAC or VFib, but it can decrease the hemodynamic performance of the heart. So we're always monitoring them. We're looking for any of these arrhythmias. You might see sinus tachycardia depending on what type of myocardial infarction they're having. But it is shown to have a poor prognosis if they're tachycardic beforehand. And this is just saying, all of the complications, like you can have the papillary muscle rupture, you can have a septum or ventricular free wall, and this is just saying things we need to watch out for mechanical complications. In the emergency department, we usually get them to the cath lab fast enough, and this is something we worry about later on, or if they're discharged and they come back. These are considerations we need to think about. So like that ventricular free wall rupture has a pretty high mortality, so 10%, usually 1 to 5 days, and that's how we kind of stratify these patients when we see them after their discharge, depending on when they go home. We want, if they had a recent catheterization, we need to think about this, or a recent stent, and then it raises our suspicion a little more depending on what time frame they presented. We'll talk about some other ones like Dressler syndrome and what that time frame is when we see it after acute coronary syndrome. We always worry about cardiogenic shock. This is usually, somebody with a significant, like right ventricular infarction. They're hypotensive initially when they present. They'll have some sort of like respiratory distress, pulmonary congestion, and these need to be treated with fluids, and then usually some sort of inotrope like dobutamine. And they're just going to get different management than their normal PCI if we identify this initially in the emergency department. An echocardiogram is a great test to help evaluate this. And then Dressler syndrome. So this is very common after acute coronary syndrome, and it's really just a pericarditis associated with wherever that infarction was. It causes inflammation in that heart muscle, or a reactive inflammation on the heart. And so, you can develop it as early as, 2 to 4 days after your myocardial infarction, but typically it's like weeks to months later. So it's important we know the history of the patient, have they had any recent procedures. If they had some sort of stent placement, then we should be concerned or suspicious for this. And what do we do for pericarditis? So they should already be on aspirin, especially if they were just discharged or if they had a recent PCI. And then we want to give them colchicine on top of it. So that colchicine and aspirin are important. Motrin doesn't help with this, or ibuprofen, because it interferes with any good effect of aspirin. And then here's just a graphic of what it looks like on the EKG for the likelihood of that ST elevation versus depression, whether it raises our suspicion for any sort of acute coronary syndrome. All right, so pearls. Get the EKG within the first 10 minutes. It needs to be read. Once you have a license, they'll make you sign them as well on all your EKGs. And then we want to get our safety net on board. We want to get our aspirin and nitro if they can tolerate it. We want to anticoagulate them. Look at the fibrinolytic checklist if you don't have PCI at your facility. And then call the cardiologist so we can get them early PCI. And then here's the take-home points of everything we covered from the beginning, which we talked about it already, but EKG 10 minutes, door to PCI 90. If you don't have PCI, then 120 minutes, and you need to get fibrinolysis in 30 minutes. And then you got to use your antiplatelet, anticoagulation, and nitrates. All right, here's some study aids. So this is just, once again, looking at your EKG findings, where those leads should show elevation, where you should see reciprocal changes. And here's a better one. I like this one, probably the best. So this one has which arteries might be involved, most commonly with STEMI, and then which location it's in, whether it's lateral, septal, anterior. So these are good little study aids. Hopefully you guys already memorized this by now. You don't even need it. Right? There's our pails again. I won't, continue beating the dead horse on this. It's important to memorize and understand this, especially with any concern for acute coronary syndrome or what you might see with a STEMI and reciprocal changes. And there's a extremely significant STEMI on there. But what questions you guys have? Anybody? You guys awake? What's the next test? Nothing on Thursday, right? Tuesday. Getting nervous about that? Is it the first one? Everybody will do good, Dr. Lester, right? All right, I'll stick around. Everybody has any questions? That's all I got.